And so next is cellulitis. It's V9. A 56-year-old diabetic on the ward presents with a hot, swollen right lower leg for 5 days after an elective right hand mycolectomy. What would you do? So swollen leg, I would take history and perform full examination. And while examination, I will see the signs of infection, area of infection, any area of fluctuation, any previous diabetic ulcer, the scars, any history or sign of skin trauma, IV access, regional lymphadenopathy, and I will review the charts. Then I will send his blood, including full blood count, UNEs, CRP, blood glucose, and culture if is spiking. And the differential here is DVT or cellulitis. This patient had a cannula removed from his right foot 2 days ago and is now paraxial. How would you treat him? The likely diagnosis is cellulitis, but I would exclude other causes of the post-paraxial agnostic leak, respiratory tract infection, urinary tract infection, wound infection, DVT, MI, and then I will swab the cannula site. Simple cellulitis can be treated with outpatient oral antibiotics, but however this patient is diabetic and systemically unwell, so I will give him IV antibiotics. And then I will mark the demarcation of the cellulitis and the monitor for progression on the treatment. This may indicate necrotizing fasciitis which needs emergency debridement. What bacteria? Streptococcus pyogenes and Staph aureus and immunocompromised patient have Pseudomonas and the rose proteus. How cellulitis is classified 1, 2, 3, 4. 4 is necrotizing fasciitis. 3 is significant systemic upset. 2 is significant comorbidities, and 1 is no systemic toxicity. So this guy is cellulitis grade 2. What antibiotics would you prescribe? So first line is fluoxetine. If allergic, then clarithromycin, erythromycin. Second line is IV fluoxetine and benzyl penicillin. If again P-eucrythral, IV tacrolimus if allergic to penicillin, and third line is IV benzyl penicillin and ciprofloxacin. But I will discuss with the microbiology. Clinically, the patient improves with the antibiotic therapy, but the erythema continues to spread. What is happening? In this case, the infection is likely to be due to the endotoxin-producing organisms such as the Staph aureus. The bacterial and exotoxins are released on the bacterial cell wall death. The exotoxins cause a local inflammatory reaction in tissues even though the infective process is resolving and the patient improves systemically. When would you consider surgical intervention? So cellulitis associated with abscess requires surgical drainage of the source of the infection for adequate treatment, and clinical concerns of necrotizing fasciitis are crepitus, circumferential cellulitis, necrotic appearing skin, rapidly evolving cellulitis, and pain disproportionate to physical examination, and severe pain and passive movement. If necrotizing fascia is suspected, I will bring the patient straight to the for debridement and do fasciotomy, and I will debride all the dead tissue until the bleeding tissue is viable and all is appeared on all the sides. I would plan a second look operation in 24 hours to debride further tissue as necessary. Thank you.